patients. And so she's going to be talking to us about lymphedema and what she does and how we can partner up with our therapists to help these patients. So thank you, Manisha.
Thank you, Dr. Ku, for this warm introduction. I've met some of you. I am, as it was just mentioned, I am an occupational lymphedema therapist. I also have board certification from Lymphology Association of North America. And just to add a little bit to my background, I've been here 18 years, but I started in acute care in the hospital on the floors before I moved to outpatient. So when I was there, I spent some time in the ENT step down unit, and that's when I realized I have interest in this patient population. And then I moved to outpatient. I was doing lymphedema for lower extremity vascular issues, and then I moved on to oncology. Next slide, please. So in terms of my head and neck lymphedema training, Dr. Ku, are you able to do full screen?
Is it full screen?
I can't tell, but okay, maybe now. This is full screen. So maybe we can go to the slide before. So in terms of my head and neck training, I went a few years ago. I went to this course for Norton lymphatic therapy, and that was a weekend course, a 2-day course. I learned a lot of things, but I felt like there was still something missing. So then I took another course from close training. I learned some more things. And then I still felt like there's something more that I needed to know about this patient population. I felt like they need something more. So I went to another course called the PORI course. It is the Physiological Oncology Rehab Institute. The instructor is based out of Denver, and then she did a real in-depth training. There was theory for 4 days, and then there was lab, and I learned a lot from this course. Not to mention that, I mean, I still use the techniques from my other courses, but in my clinical day to day, I used more techniques from the PORI course because I felt like they were very practical and very applicable to the patient impairments. Next slide. I can't start my presentation without thanking the speech therapy team. And a shout out to Molly Smeltzer for taking the initiative to start the discussion on lymphedema and getting this incorporated with the head and neck cancer population. I have no disclosures, and I've taken permission from the patient for all the pictures I will be showing today. So my objectives are talking about assessment and treatment, side effects, and the quality of life in this patient population. Assessment. So I will start with some impairments. So these are the main impairments that I am going to talk about today. There are more, but I felt like these were more common, and I see them most, and they impact the patient most. So first is swelling or lymphedema. So when the patients come to us after surgery or before radiation, or even when they have started a little bit into a few weeks into radiation, so swelling or lymphedema is the most common concern of the patient. So one might say, this is post-operative swelling, is not really lymphedema, and that's true. But most of the time, the lymph nodes have been removed in this patient population. So we're already that puts the patient already at subclinical lymphedema. And that's important to treat because lymphedema is the lymphatic fluid is not just fluid, it's not just water. It is a proteinaceous fluid. It has proteins in it. So if left untreated, it can become hard and then it can turn into a to a very hard swelling type of lymphedema, like a severe stage. So we want to treat it. And I will talk more about all of these impairments individually in my future slides. So the next is trismus. It is joint tightness. It's called lockjaw, decreased mouth opening. So it is due to many reasons, due to radiation, due to surgery, due to pain, due to just fear of not moving that operative area. Um, so it can cause some joint tightness. Then is pain. So pain is, we know, when the patient comes out of surgery or when they are recovering, there's pain. But the pain in this case can lead to all of these impairments, and these impairments can happen because of pain. So there's pain in the neck, pain in the mouth, in the tongue, in the side where the scar is, or the swelling itself can cause pain, or there's pain just because of non-use or fear of movement. And all of these things can cause decreased joint range of motion in the neck and shoulder and in other upper body. So all of these are kind of related with each other. And interestingly, if we work one area, the other areas also start to show improvement. And the last one is scar adhesion. So I have it on this slide a little bit, I have space between the four and the fourth and the fifth, because typically, you may not think scar as an impairment because it's a scar, it should get better. But in this patient population, it is so significant that I felt like it bears mentioning on this slide. It's the scar tightness can cause accumulation of swelling, and the side where the scar is on the neck, patients can it can lead to muscle tightness that can lead to joint pain, joint discomfort, decreased joint range of motion, and all of these impairments. So sometimes we work so much on the scar in a session that is a significant impairment for us to work on. Next slide. So now I'm going to talk about the measurements. So I'm just going to be honest and say, at this time, we don't have any reliable and a good way of measuring the swelling on the outside. So there is tape measure, and the first picture is the submental swelling. So I measure submental swelling in almost every patient. It's very easy. There are two fixed points, the chin and the knot. So it's very easy to measure. So, and we measure periodically to see if there's a change. And of course, there is a visible change also. The next is the facial measurements. So there are a lot of measurements, as you can see, from different points on the face, from the chin to the tragus, to the angle of the mouth, to the angle of the ear, and to the jawline. These are a lot of measurements. And all of these measurements are also done on the other side of the face. And then there is a MET formula that we do to see if we add it, and there is a formula where we see if it's a 2% or something like that of a change. So it's very time consuming, and there's potential for error with the tape measure because tape can move. If the person is not sitting one way, if their head is forward flexed or if extended, or if they're sitting in a different way because of pain, the measurements are not consistent. So sometimes I don't measure all of these. I just measure the relevant ones, just because of time, and then there is a lot of potential for error. So the next is pictures. I rely more on pictures. Pictures give a very good idea of the pre and post. Um, it is also very good for the patient feedback to see where they are, and also for us clinicians, or if we are discussing amongst clinicians, it's very easy to convey if the patient is progressing or not. Next slide, please. This is a measurement of the severity of swelling. So that is, it's a very good scale. It's a definite scale, and it's called a modified Foldy scale. So it goes, it's very detailed. It's from 0 to 3, from no visible, sub-visible, pitting, form, and then irreversible. So it's very, very accurate. And I believe it's the same scale that's also used by MD Anderson. Next slide, please. This is for measuring trismus. This is not a patient, this is just a picture. So it's a range of motion paper that typically in the picture, the person is holding the paper by themselves, but in the clinic, I hold the paper for the patient. Sometimes they may not have teeth or they may have a flap on the top. So I want to make sure that I have um, consistency in the way I'm measuring. So we measured the mouth opening and the lateral excursion um, to the right and to the left. Next slide. This is range of motion for neck and shoulder. There are two ways of measuring. The first is the goniometry, which shows in the picture on the top, to shoulder and the neck. It's very quick and easy, um, and it's easy to do in the clinic. The second one is the cervical range of motion. It is supposed to be more accurate, but as you can see in the picture, there it's a big device. It goes on the head, in the forehead. There are three dials that accurately measure the directions of the neck range of motion, and there are magnetic pads that lay on the shoulder. So the downside of that is that if there is trach or incision, it is very close to that, and the patients don't feel comfortable having anything. You can imagine that the patients will not like that very close to their incision or the neck. Um, and the pads are magnetic, so we just have to be careful um, if their patient has a pacemaker or any such thing, that it doesn't, it's not a contraindication for them. Next slide. So now I'm going to go into treatment. So swelling or lymphedema. So the goal of our goal with this is to move the fluid from the congested areas to the uncongested areas. So as you can see in the picture, it goes all the way. So our goal is to, so for the head and neck, we typically move the fluid from into the either so supraclavicular fossa, posteriorly, or in the axillary area. Those are the three main areas that we're trying to move the fluid into to move from the congested to the uncongested areas. In all of these techniques, the manual lymphatic drainage, compression with the bandaging or the garment or with the taping, all of these three techniques do this. It helps the goal of these techniques is to move the fluid away to the uncongested area so that it can go back into the circulation and excrete it out via the kidneys. And now I'm going to now go into detail of what each component entails. Next slide, please. So what is manual lymphatic drainage? Manual lymphatic drainage is a gentle skin stretch. It is, colloquially it's called massage, but it's nothing close to massage that is given in salons. It is a gentle skin stretch to move the lymph vessels, so to move the fluid. So in the picture on the left, there's a diagram of the skin. There is epidermis, dermis, and these are the lymph vessels in the green. So this is on the right. This is an enlarged lymph vessel, and each of these is a unit, which is called the lymphangion. So in the circulatory system, the the arteries and veins have their own mechanism of pumping the fluid due to the heart pumping. But the lymph system has no self mechanism of pumping. The fluid moves by movement of the valves in the lymph vessels. And the valves depend on the movement of the muscle and joint to move. So when I'm doing the skin stretch, I am facilitating the movement of the fluid through the lymph vessels. So lymph system is very superficial. So I'm able to do that just by moving, just by doing the MLD. And that movement is called lymphangian motoricity. And then down here is an enlarged picture. So because the valves in the lymph vessels depend on the movement of the muscle and joint, herein lies the importance of, the improving the muscle tightness, having the patient do joint range of motion, doing the myofascial release or soft tissue work. And all of this helps the patient to helps with the movement of the fluid. Next slide, please. So this is the manual lymphatic drainage pictures of for the face, neck, cheek, tongue, and lips. So we can do manual lymphatic drainage for all of these areas. The first two pictures on the top is me with the patient working on the patient. And so it's, starting from the forehead, going down to the sides of the face and to the neck. And it's a very detailed process. So I've just shown just a snippet of what I do. But you start from all the way from forehead. You can go up to the eyes, parts, around the nose, top of the lips, inside the lips, then the chin and the neck. And I'm trying to move the fluid to the supraclavicular fossa area or axillary area or posteriorly. And and before that, you work, if there's a scar, you work on the scar, or you can kind of move through the scar. So there is plenty of research now. We used to think that we have to go around the scar, but we have found that the lymph vessels can grow through the scar. So um, when when we open the scar and just keep going, move through the scar, the results are best. And then the pictures on the bottom two pictures it's not a patient, but it's just to show the movement. The one on the left here is the cheek. The arrows are pointing where it goes. So the movement is posteriorly and inferiorly. Um, and on the tongue is from middle to the middle to laterally. So the tongue actually is, you know, um, initially when I learned the movement of the tongue, I used to think that I don't know if it's going to do anything, but it's so interesting and it's so surprising that for all of the glossectomy patients, when I do that on the tongue, initially the patients feel like, "What are you doing?" But they feel so much relief. There is this superficial puffiness. It's very hard to say if it's the fluid or the swelling or what it is. There's no way of knowing. But in some patients, that superficial puffiness goes down right away. And it brings such a big relief to them in the mouth because now they have more space in the mouth. They can talk better. They just feel a lot of relief. So the next is kinesio tape. So kinesio tape, it looks like this. It's on the right-hand side. It's an elastic tape. So I knew if you are in sports, a few years ago, the taping was done in the Olympics. All of the athletes wore the tape, and it became very popular then. The name comes from the person who developed it. His name was Kenzo Kase, and the way the taping, it has no medication in it. The way it works on the basis of the tissue stretch and the tension in the tape. So the amount of tension in the tape dictates what we're doing. So for pain, it's a little bit of tension. For the swelling, it's not a lot of tension. For scar, it's a lot of tension. So the way the tape is applied, it it depends on, it dictates what we're working on. So if you see the picture of the tape on the left hand side, there is the epidermis, dermis, lymphatic fluid, and you see these angry faces. So there is no room, and so it's everything is so tight. So this is the taping for the scar. The picture is for the scar. Everything is really tight, and then when the tape is applied for the scar, if the tape is stretched more than 50%, the skin is lifted up. So on the right hand side, the skin is lifted up, and there is room in between the dermis and the lymphatic fluid. So you see these happy faces, and the fluid can flow easily. So that helps. So in some cases, if the person is only, let's say, if they are, about 5 6 weeks out from surgery and their skin is completely healed, so um, we don't want to apply tape on the skin that has not healed or it has radiation changes. If the skin has completely healed, then the tape should be applied. I mean, it's contraindicated for any skin that's healing. So it's either is there if either they are post radiation and they have all the treatments done, or they are in between surgery and radiation when the skin has completely healed. So those are the good times to apply the tape. And then sometimes you can see improvement within the session if the tape is applied and it's removed, or the tape is applied, the scar loosens up and the fluid dissipates right away. So this is a picture. This is one of my patients, and so the tape is applied also for softer swelling. It works best versus a fibrotic swelling. So from the left to right, the first picture is, so this between the first and the last picture, this happened in a span of 6 days. So the first picture, patient had a lot of swelling, and I was trying everything, and nothing was working. And then I thought, well, let me try taping. So I did my MLD session, I did everything, and then I applied taping after that. So I didn't have a chance to show a picture of taping on the swollen face. So I'm just showing the pictures just to show how the tape is applied. Um, but she responded beautifully on the last picture. So the way the tape is applied, like I was saying, there are different styles and different tension of the tape to apply for what we want to work on. So for the swelling, tape is applied in a fan shape. So there are these strips, and there the anchor is done posteriorly. So the anchor is where we want the move to the fluid to. So we want to move the fluid to posteriorly. So the anchor is posterior and the fans are fan shaped, is on the face. So this also helps in between sessions. So when we have worked with the patient goes home, then what is there to prevent refilling of the tissues? So something like a tape will help. So if it's a milder swelling, or the patient says, well, I don't want to wear any garment, I don't want to do, they feel like it's too much, which it can be too much. So then the tape helps to maintain the gains they have made in therapy from session to session. So of course, it is not a permanent solution, but it helps the patient to give them something to hang on to. And with time, when the swelling is somewhat controlled, then we can go on to do different things. So in the last picture, there is a sunken cheek, and the tape was able to maintain that. And she also showed some decrease in swelling in the submental area. The next slide, please. So this is a picture of also my patient. The top one is, so he has swelling on the right side of the face and submental. So there's pre and post. This improvement was in one session. So I did manual lymphatic drainage on him. So his face, and he showed improvement right away. His swelling was a little bit harder. The submental was fibrotic. So with that kind of swelling, I can gauge my pressure when I'm doing my MLD, and I can, the improvement happens very quickly. But for this type of swelling, they may not respond to taping very well. So I'm showing the picture on the bottom to show that the kinesio taping didn't really help for this person in the neck area because his swelling was fibrotic. So he still has that um, waddle, but the face was softer swelling, so that came down. So this picture is, the first one was I applied the tape, and then I asked him to send me a picture next day morning to just for me to see if it actually worked. And he sent me a picture, and I was kind of I was not surprised that it didn't work as well as the MLD in this case. And this is a picture of short stretch compression bandaging. So that's another alternative to compression garment. So short stretch bandaging, it looks like ACE wrap, but it's not ACE wrap. It is a bandage that's specifically for lymphedema swelling. So it is short stretch, meaning it doesn't stretch. It stretches about 100 to 150% as compared to ACE wrap that stretches about 300%. So this is initially when the patient needs some kind of compression. So after we have done work during the session, all the manual work, then I send the patient home with something like this so that we can maintain the gains. Again, what is there to prevent the refilling of the tissues? The compression bandaging really helps. So there is the bandaging, this is the front and this is the side. And the foam piece that's inside goes on the submental part, the harder part of the swelling. So this patient had swelling more in the submental and the neck area versus the face. So I put the foam submentally. Um, Also, it's initially when the patients need all of this just treatment, it's it's just easier for also easier and to us for us to do bandaging to see if the patient even responds to bandaging, because the way they respond to bandaging will also determine if they will respond to compression garment. um, Sometimes I don't recommend compression garment right away because it's not easily accessible. If it was something that we could just pull out from our cupboards and give it to the patient, that would be a different story. But every patient is different. Their measurements are different. Um, the style of the garment required for them is different. So um, it's more beneficial to have to start with the bandaging first and to kind of get the patient used to having something on their face and for them to see that it really works. Once they see that it works, then they're more apt to wearing a garment if it's still needed. Yep, next slide, please. So this is the slide of all the garments. As you can see, it's hard, it's big, it's awkward, it's cumbersome. There is no easy way to compress the head and neck area in terms of long-term compression if they still have swelling. So I w- I would keep this I keep this as the last resort, um, just to give patient time to understand what and for us as clinicians to see what is really working and what's not working. So I really worked with the patient on this. I kind of meet them where they are, um, give them time. They are going through a lot of treatments, and it's a lot for them. So I try to give them time and see what actually works, what doesn't work. And if by the time we get to like third or fourth week or even fifth or sixth week, and when the patient sees that what we are doing is working, then they're more than happy to wear the garment. There is increased compliance at that point, um, when they are when it's time to wear the garment, if they have gone through all of these treatments. The next one. So one step at a time. So I just wanted to put this slide in because patients go through a lot. It's a lot. They have a lot of treatments going on. The diagnosis in itself is a challenge to come to terms with, and just to even for us as clinicians, sometimes, we're scratching our heads, to give patients relief. So just to remember to take one step at a time and to start from where we are. So trismus treatments, intraoral myofascial release works really well with these patients. If the trismus is from surgical issues, radiation, or just non-use or fear of movement. And then followed by active range of motion stretches. So these are some of the pictures of myofascial release. People have asked me, what do you do? So I put some what pictures to show. So the myofascial release for this is external and internal. So typically I work on the masseter, and the pterygoids, and internally I work the lateral and medial pterygoid and also masseter. And so it's typically, if they are tight, they show some improvement, if not all. So these techniques, they work really well once the patient gets used to working inside their mouth. Is it then they show improvement. And conversely, when they see improvement, they're more likely for us to be to more amenable for us to work inside their mouth. And then these are the jaw range of motion stretches that I give. I also coordinate with speech on this. The speech therapy also works on their jaw, and they are also giving the recommendation on the devices. So I work with the speech therapists in the hospital, coordinate with them, the ones who work in TASIG and with the head and neck cancer population. They do all the paperwork for the devices such as Terabyte or Aura Stretch. And then for jaw tightness, I say that the more the better. Whatever the patient can use is fine. Sometimes they just want to use the device. Sometimes they want to do the stretches. Whatever it works for them. If they can do anything to do something at home, it's helpful. So this is a picture of a Batman and Robin. So we have been nicknamed lovingly, the speech therapist and the lymphedema therapist as Batman and Robin. And I agree with our relationship. We work very well. We coordinate with this patient population. It is so important to coordinate care. And the patients also feel confident when they see that all the team members are working together. They have confidence in the care we provide. Scar adhesions is it's very significant in this patient population. So we can do either manual scar mobilization, um, doing kinesio tape, as I had just mentioned, and sometimes just using silicone gel or sheets. Again, if the skin is healing, or if it's open or going through radiation, then we don't want to apply anything such as kinesio tape or silicone gel. So that's where we're limited sometimes and just do manual work. gentle manual work, or just leave it alone in some cases, and that may slow down the progress, but sometimes we just have to work with how the skin is healing. So this is pain and posture, very significant in our patient population. The pain could be due to improper posture, and improper posture could be due to pain. So these are very related to each other, these two areas. The pain can be in the jaw, the face, and the neck, or could be due to the sleeping one way, or could be if the patient still is working and they have a desk job. So to kind of make sure that their arms are resting, they're not favoring their operative side, and then just to give them reassurance that it's okay to move, it's okay to move their arms, it's okay to move their head and neck, to give them, just give them reassurance, but at the same time also keep working manually, um, to to show them that it's okay to work in that area. A lot of times patients don't move because of fear, or they just don't know how much to move. So us working on all of the soft tissue work, um, manual lymphatic drainage, myofascial release, proper positioning, it helps them to understand how much to move, and then it's okay to position normally. So this is a summary of one of the patients that I had shown earlier. So if you can see, this is 1, 2, 3, 4, and 5. So it so the things that I have mentioned, components that I've mentioned on the left-hand side are myofascial release, manual lymphatic drainage, scar work, compression garment, and range of motion. So all of this, it takes all of this for the patient to feel better. So you can imagine it's a lot for the patient. This patient has been very compliant. So she was even willing to wear a garment like this in the fourth picture. Her face swelling, as you can see in the first picture, was so much that nothing worked until she wore this kind of garment. And even then, the swelling was coming through these holes to the lips, and then her lips were getting swollen. So then we had something for the lip compression. So it's just, it takes a lot of effort on, on the patient's part, on our part, and just to kind of give time to the patient to see what works with them, and sometimes just to give a break, and just do something else like range of motion exercises, or just something light and easy like kinesio taping, to give a break to the skin, and then just for their emotional well-being, kind of give reassurance, just keep on working. So exercise is very, very important, and there are so many aspects to exercise. There are so many exercises for the neck and shoulder. I did not put everything here, but to say that exercise is important, not just for physical, but also for emotional well-being. Something as simple as walking out in the nature can be helpful. Patients don't have to go to the gym and do heavy lifting. They can do just yoga or Pilates, or something as simple as that can be very helpful. So this is late side effects, meaning, after radiation, what are the prolonged or side effects that take a long time to mitigate, or to work on, or to sometimes they are just there to stay. So it's internal lymphedema, radiation fibrosis, and abnormal head and neck posturing. Internal lymphedema is kind of the most important out of all these. Um, Next slide, please. And so I, my speech therapy colleagues alert me on this, because they do the imaging testing. They do the modified barium and the fibrous, the endoscopy. And when they see this, they alert us right away. Hey, the person has internal lymphedema. Can you do something? So this is important because the internal lymphedema actually affects the vital functions of the patient. So it's the swallowing, the voice quality, the speaking, the talking. Decreased airway can cause breathing issues. So it becomes really important to work this area. Next slide, please. The treatment for this is internal mouth work. So a lot of intraoral work, myofascial release, manual lymphatic drainage, and head and neck posturing. So um, I have talked some about in myofascial release and manual lymphatic drainage intraorally, but also head and neck posturing. So if the person is, we do all this work in the clinic, and if the person sits with forward head or hiked up shoulders or favoring their, sort of the head and neck area, or sleeping with head flat, then the fluid tends to accumulate in the head and neck due to gravity. So if the person is sleeping flat without the head and neck elevation, due to gravity, the fluid will accumulate in the head and neck. So all of this work can be, they can maintain what they have achieved in therapy by working on their posture. During the day, if they can work on their head and neck strengthening exercises, which, our multidisciplinary team, such as physical therapy, can work with them, and they often work with them on these exercises when they're being referred to them. So all of this components help with internal lymphedema. The next one is radiation fibrosis. That is one of the most difficult things to manage, actually, because radiation fibrosis is just really, it shows up really late, and the skin is hard and fibrotic. And oftentimes it's in the area of radiation, which is the neck. And it's very hard. So manual work is definitely helpful, but it's very hard to do anything else. There is compression bandaging, the denser foam padding, but sometimes it's not really comfortable. Um, or it's just if the person is too far out from the surgery, then or their medical treatment, then it's just something that's hard to manage. So we do the best we can and just keep focusing on daily compression and exercises to kind of manage it somewhat to decrease their pain. Even if they still have fibrosis, but if they don't have pain and if they have movement, they feel like they have some quality of life. The next segment is quality of life. So in our cancer, in this patient population, that is a very big component, as we all know. Um, this affects all of this treatment is important to get their disease out, but unfortunately, it leaves some side effects that we're all trying to work on. Um, and the patients, these are some of the comments that patients have said that I can't taste my food, or I have, I wish someone would have told me, or I have something always in the back of my throat. Um, and so we know that these are some side effects. Next slide, please. That really impair the patient. Their hoarse voice, difficulty swallowing. They have frequent bouts of coughing at night. They have altered taste or dry mouth. That can be due to the dry mouth can cause coughing, or they could have swelling internally that can cause coughing. And it impacts them socially and psychologically also. So um, what we can do is, just reassure the patient and educate them. Next slide, please. And we work as a multidisciplinary team, so that reassures the patient a lot. And then head and neck rehab is a team sport. I don't think I could do this without any one of you. So I'm very appreciative to work with all of you to help our patients. Thank you very much.
Thank you, Manisha. That was a great overview, especially giving us an insight into what you do as a lymphedema therapist for our head and neck patients. I'm gonna, it's actually 8 o'clock. Maybe we can open up for a few questions. So I have a question. So do you also work on like, because, obviously many of these patients get free flap reconstruction and there's just inherent post-op edema and maybe even lymphedema of that flap tissue. Do you also work on those tissues?
Um, I don't I don't know if we have specifically worked on that as yet. I have worked on internal mouth swelling, but to be honest, I'm still learning about these surgical procedures. So I it's something definitely that we can work on if there are no contraindications, and if from surgical point of view, if you think that it's okay to work inside the mouth, then it's definitely worth trying.
Personal thing is, obviously may not be safe to do it in the immediate post-op period as they're healing, but I think
Yeah.
long term it should be safe once it's healed in. Maybe one more question? All right, I'll end with one final question. So I know like a lot of us are trying to move towards even like you said, patients which they knew earlier on or was educated even prior to any treatment. Do you find seeing patients before they have undergo surgery or radiation, do you find that to be helpful? Or do you think, because sometimes, like you said, the patients are overwhelmed, there's a lot of appointments. Sometimes they have to prioritize and they don't always make it to you pre-treatment. Do you think that's critical in education and expectation management?
So that is a question that all oncology is pondering. All kinds of oncology are pondering how to create a balance between not overwhelming the patient but still providing them education. So we want to provide education but I don't know how. Maybe we can discuss this as a team, how to provide it. Should we do a handout, or should we do maybe a video that the patient can watch without being with a provider, or should we do a separate visit? um, it's definitely a hard balance between overwhelming them but also giving them information. And I think it's something that we can discuss this as a team.
Sounds good. All right, well, thank you so much, everyone, for joining and have a great Wednesday.
Thank you, everyone.